function and pulmonary artery pressures, and tricuspid valve regurgitation using echocardiographic assessment tools. So first we want to talk about the why examine the RV. As many of you know, it is affected in many cardiac diseases and is an important cause of hypotension and shock in many settings, be it the medical ICU settings or the surgical ICU settings. Certainly, the RV plays a major role in the evaluation of patients with congenital heart disease, and it has been shown to be associated with outcomes in many patient populations, be it patients with myocardial infarction, heart failure, valvular heart disease, pulmonary hypertension, and primary cardiomyopathic disorders. The RV in a short axis is crescent-shaped, and if you're using 2D and not 3D, it is difficult to get to see all portions of the RV in the same view. And therefore, we rely on multiple views. The standard views we use for the LV will be utilized, as well as additional views geared towards looking specifically at the RV. So today, my emphasis when I describe the parasternal long axis view is looking at that area of the RV outflow tract. You can see the part of the anterior wall of the right ventricular outflow tract, and you can measure the dimension between that anterior free wall and the junction between the septum and the aortic root. This is referred to as a proximal, if you would, or gives you an assessment of the proximal region of the right ventricular outflow tract, and the upper limits of normal is 35 millimeters. It's the first look at the RV, so to say, when you start the exam, should not be the final look. You should be cautious that oblique views will give you the impression that the right ventricle is larger than its true size. The next view I will speak about is the parasternal long axis view. And as its name emphasizes, it's a long axis view of the right ventricular outflow tract. You see the pulmonic valve, and you see the portion of the pulmonary artery above the pulmonic valve. As you can imagine, we can do several linear dimensions here for the outflow tract. And importantly, we can also use Dopplers to align with some of the flows through the region. A third parasternal position that we use, still long axis view, is one that shows us the RV inflow. You see the right atrium, the right ventricle. We see the anterior wall of the right ventricle, the inferior wall of the right ventricle. In patients with coronary disease and dependent on the affected artery, you can see segmental dysfunction as opposed to global dysfunction, which can happen in other situations. You also see both leaflets, anterior posterior leaflets of the tricuspid valve, the two papillary muscles. You can put Doppler, you can interrogate the tricuspid valve here and look for tricuspid regurg, some of the qualitative Doppler parameters. And in some patients, you can see the coronary signs. We have a short axis views likewise. So we talked about 3 parasternal long axis views. We're talking here about 3 parasternal short axis views. The first one is at the level of the heart. It gets you the aortic valve, the pulmonic valve, the tricuspid valve, both atria. And you can do a measurement here for the distal area or region of the right ventricular outflow tract. It's a linear measurement. And the upper limits of normal per the American Society of Echo guidelines is 27 millimeters. Because we are able to see the septum, we can interrogate the septum by color, and if patients have PFOs or atrial septal defects, these are very well approachable here. Likewise, because you see the tricuspid valve leaflets, you can look at the tricuspid regurg with color, and you can align reasonably well with the tricuspid regurgitation jet. In a parasternal short axis view at a higher level can get you the RV outflow tract, the pulmonic valve, and the bifurcation of the pulmonary artery. Excellent alignment for Doppler signals, somebody with infundibular pulmonary stenosis, pulmonary valve stenosis. Supravalvular pathology in the vicinity of the pulmonic valve are all approachable from this position, and is a very important view in patients with congenital heart disease. Then we have the parasternal short axis view that outlines to you nicely the crescent-shaped short axis of the right ventricle, and you can see the anterior, lateral, and inferior walls. You look at the interventricular septum and its behavior. When does it become flattened? If it does, systole or diastole, and that can provide insights into volume overload and pressure overload situations of the left ventricle. Moving away from the parasternal position, we'll go to the apical position. And this first position we look at is the apical four-chamber view. An important notice here, the apical four-chamber view was designed primarily to show you the left ventricle and the left atrium, as opposed to the right ventricle and the right atrium. So in many patients, we do not see that well the free wall of the right ventricle or the lateral wall of the right ventricle. And it's important when we want to think and assess right ventricular size and function. So keep in mind, therefore, the need for other views. But while we are in the apical four-chamber view, again, you can look at the interatrial septum. You can look at the right atrium, the right ventricular size and their relation. You can look at the tricuspid valve for pathology of the valve leaflets, for tricuspid regurgitation, and also aligning with the tricuspid regurgitation jet. Also in this view, we're going to use the MO to align with the tricuspid annular plane, to look at the tricuspid annular plane systolic excursion or TAPSE. And in this view, we are going to record using tissue Doppler, pulse wave tissue Doppler, the tricuspid annular velocities at the lateral edge of the tricuspid valve. Given the importance of seeing the RV free wall, one can think of the need of other views, and indeed other views are available that emphasize different walls and different aspects of the RV. The one that is routinely obtained and is part of the proper complete 2D Doppler exam of cases referred for a complete study in transthoracic imaging. And certainly if there are concerns about RV function for one reason or another, is the RV focus view. That's a standard view that should be obtained in all patients. And in this view, the center of the sector, as you can see here, becomes the LV apex, and that opens up the base of the right ventricle. Once you open up the base of the right ventricle and you bring in the lateral wall, you have a very decent view of the RV. You can do your measurements of dimensions, linear dimensions of areas, get fractional area change, and you can certainly look at the tricuspid valve leaflets, tricuspid regurg, and align with it with Doppler as well. There is also another view that brings up the lateral wall nicely. It's the RV modified apical four-chamber view. A word of caution, this is not a view that we want to use for RA volume or RA size assessment, as it tends to foreshorten the right atrium, but it gives you a very good look at the RV lateral wall. Sometimes we do bubble studies to look for shunting, and that is a good view that would allow you to visualize the presence of shunting. And certainly you can interrogate the interatrial septum, the tricuspid valve, and tricuspid regurg as well. Going back to mention two quick views, one that brings in the anterolateral wall of the right ventricle and shows you nicely the moderator band is the RV apical five-chamber view, whereas the apical coronary sinus view brings you more of the posterolateral wall of that right ventricle, and as you see nicely, the coronary sinus. Subcostal views are in some patients the only views that we have to look at the heart because there are no parasternal or apical windows that you rely on. And it is important to take advantage of these views. Also, this is the view which is recommended to measure RV wall thickness. I'll come to that in a few slides. You can look here at the right atrium, left atrium, interatrial septum, and if there is a patient with a PFO or ASD, something that is, say, acquired after a clip PFO, you can align nicely with the flow between the atria and get very good parallel alignment. It is not used to quantify RV or RA size, more of sort of a feel of how they compare to the left ventricle and left atrial sizes. Also, if you rotate from that position, you can get to a short axis position, and here you can get very good alignments with flow through the RV outflow tract and the pulmonic valve. So now that we have looked at the views that we use and the utility of them, let's look quickly at the blood supply of the right ventricle. It gets its blood supply mainly from the right coronary artery and its branches. The anterior wall of the right ventricle gets its blood supply from the acute marginal branch, whereas the inferior wall gets its blood supply from the posterior descending coronary artery. The right ventricular outflow tract largely gets its blood supply from the conus branch. It's a very small vessel that comes up the right coronary artery, at times really hard to see or cannulate, which is good. If you inject into it, it can cause ventricular arrhythmias. When we look at the lateral wall of the RV, it gets its blood supply from the acute marginal branch of the right coronary artery, whereas the moderator band and the apex of the RV, as well as the distal septum, get their blood supply from the left anterior descending coronary artery, which can explain the apical dysfunction that you see sometimes in the RV apex in patients with an LAD stenosis. As to the inferior interventricular septum, both basal and mid segments get their blood supply from the posterior descending coronary artery. These are important to remember when you're looking at the RV function, segmental function in patients with coronary artery disease that involve the RCA distribution. We mentioned talking about the RV free wall thickness, and the best place to measure the free wall thickness is in the subcostal view, because here we are using the axial resolution. It varies from 1 to at most 5 millimeters, so the normal is less than 5 millimeters. You want to zoom, as you see in this nice example, and you want to measure it end diastole. Trabeculations are out. Visceral fat is out. In some patients where there is a lot of fat, where there is pericardial thickening, it becomes difficult to obtain a reliable measurement of the wall thickness. Where exactly do you measure the wall thickness? It's below the tricuspid annular plane, usually in line with the distal end of the anterior leaflet of the tricuspid valve when it's fully open and parallel to the RV free wall. How about ventricular dimensions? Dimensions are easy to obtain, and hence we tend to use them a lot. The problem with the dimensions is when you look at the upper limits of normal, they have not been necessarily indexed to the body size. And so a value for someone of a smaller size may be abnormal for their small size. But nevertheless, if I don't index that to their size, it would not be noted. Having said that, what are the dimensions that are recommended? Again, I'm going by the guidelines. The first one is the basal dimension of the ventricle from the septal to the lateral side below the tricuspid annulus, and you want to get it in that RV focused view that shows you the maximum size of the right ventricle. Otherwise, you foreshorten and you end up with a smaller value. The upper limits of normal for this dimension at the base is 41 millimeters. Another dimension can be obtained usually at the level of the pap muscles, midway between that basal dimension and the apex of the ventricle, and the upper limits for that one is 35 millimeters. Lastly, the long axis of the left ventricle from the base to the apex, and the upper limits of normal is 83 millimeters. Now that we talked about the dimensions, is that the only index of RV size? No, we can look at the area. Before I delve into the fractional area change and how it is measured and its limits of normal, I want you to know that this is just looking at one segment of the RV. The outflow tract is not captured here. And so it is not an equivalent for a right ventricular ejection fraction. Having said that, there are several published studies that compare the RV fractional area changed against the right ventricular ejection fraction by radionuclide ventriculography and showed good correlations. How do we get the fractional area change and what are its limitations? We get it by tracing the endocardium of the RV free wall, starting from the level of the tricuspid annulus all the way to the apex and up to the septum till I reach the medial side of the tricuspid annulus. I look at the largest area at end diastole and the smallest area at end systole. The difference between them divided by the end diastolic area is the fractional area change. The lower limits of normal is 35%. Less than that is abnormally reduced. You can see here examples of a really functioning well RV one that is, you can say, lower limits of normal at 40%, and one that is clearly depressed. The challenges with it are the following. Do I show the true size of the RV or do I not show it? If the right ventricle is foreshortened, there are problems. Is the apex well visualized or not? Are the endocardial borders clearly seen or not? Also, you need to exclude the PAPSE and the trabeculae. These become parts of the cavity. As you expect, it's not a pure metric of contractility, but is also affected by loading conditions. The same aspect, whether you look at many other indices that we will talk about, including ejection fraction by radionuclide ventriculography and CMR. Let's look at another index that has been looked at over the years. Before I proceed, this is these indices are more used for research purposes as opposed for day-to-day applications. The first one is a rate of change in pressure versus time during systole. Since the tricuspid regurgitation jet is a reflection of the pressure gradient between the right ventricle and the right atrium, you can expect it to relate to the right ventricle. If you make the assumption that the right atrial pressure is changing little in that aspect, then changes that we see in the velocity can be attributed to changes in the right ventricular systolic pressure. And so if we want to calculate that, we want to look at a pressure change. We choose 2 time points, one at a point when the peak velocity is 1 meter per second, and another when the velocity is 2 meters per second. If you use the modified Bernoulli equation and you convert these velocities using 4v squared to pressure gradients, you end up with a dP of 16 minus 4. And then all you have to do is just measure the time between when the velocity was 1 meter per second and when it was 2 meters per second. It is also possible to use this more qualitatively, like how fast does it go up? A faster rise means a better performance. You can also look at the descending phase as an index of diastolic function. The slower it takes for the pressure to drop, the worse the relaxation. Again, more of qualitative as opposed to quantitative aspects. How about another index? Another index is the TAE index, or myocardial performance index. And the idea here is that the less time the ventricle wastes in ejection, the better its performance. So the longer the time of the cardiac cycle spent during ejection, the better the performance. To figure out that index, you need to add the isovolumic contraction time and the isovolumic relaxation time and divided by the ejection time. Because the ejection time is obtained from the RV outflow tract, which is in a different view than that used to acquire tricuspid inflow, basically the apical view. One approach that avoids multiple views and different RR intervals, although there will be some variation in the RR interval still that you have to consider, is relying on the tricuspid regurgitation jet. Tricuspid regurgitation takes place during isovolumic contraction, ejection, and relaxation. If you subtract from that duration of the tricuspid valve the ejection time as acquired from the RV outflow tract, then you have the numerator of the expression. The upper limits of normal is a ratio of 0.43. If you want to use one cardiac cycle, but now rely on tissue Doppler signals of the tricuspid annulus, you can add the isovolumic contraction time here and isovolumic relaxation time here and divided by the ejection time. For tissue Doppler, a value more than 0.54 is considered abnormal. The utility of this index is its, you can say, simplicity. The problem with it is that you include in the numerator the isovolumic relaxation time. When patients have a high right atrial pressure, that isovolumic relaxation time shortens, which means the ratio drops, giving you the false impression that function has improved when it's actually worse diastolic function, explaining the findings. We mentioned the tricuspid annular plane systolic excursion, acquiring it from the apical 4-chamber view, trying to align with the tricuspid annular plane excursion. It's a simple measurement, has been used in several disease states, has been related to RV ejection fraction by ventriculography using radionuclide techniques. shown to be associated with outcome. And for all these reasons, people like measuring it, and it's not a challenge to measure it. You look at the end diastole and you look at the end systole, as you see here, and you measure the vertical distance between them. The lower limits of normal is 17 millimeters. The problem with this index is it's looking at motion relative to the transducer position. And so when I use the word motion, it's not just contraction or shortening of the RV lung axis, but it's also cardiac translation and rotation. Another approach to look at how much the tricuspid annulus moves or how fast it moves is looking at the ejection velocity, be it with the spectral Doppler display here or with color-coded tissue Doppler. We do not use color-coded tissue Doppler nowadays. There was an interest in it in looking at synchrony indices because you can compare the performance of different segments in the same cardiac cycle. We use nowadays the tissue Doppler. The lower limits of normal for this velocity is 9.5 centimeters per second. And again, you need good alignment. And all of the concerns that we raised with respect to motion of the annulus relative to the apical transducer location apply to the tricuspid S prime velocity likewise. Has also shown some modest correlations with ejection fraction by CMR, and all of them are indeed indices of systolic function during the ejection phase of the ventricle. A particular situation where motion of the heart is exaggerated is after thoracotomy. And so be careful with it in drawing conclusions when you look at these exaggerated motion in settings as heart transplant patients. We just mentioned open thoracotomy or pulmonary thromboendarterectomy patients. This may look preserved when function is actually depressed. Moving away from the limitation of motion or how much motion affects the velocity is the comparison of 2 points and how they move now relative to one another, looking at strain and strain rate curves. At first, this was done by tissue Doppler, which has a very high frame rate and is affected, as you expect, by the Doppler principle. This is an early validation study using sonomicrometry against echocardiography to measure RV strain and showing a good correlation. We have moved now from relying on tissue Doppler to using speckle tracking. And with speckle tracking, you can look at both the free wall, the septum as well, or just the free wall. The advantage of looking primarily at the free wall is because the septum is shared by both chambers. So the thought this is a more pure metric of RV function. It is a good index of RV function, but it's still affected by loading conditions. It is also affected by the image quality. If you do not see the RV free wall well, if the contours extend outside the epicardium, then, and if you do not see the endocardium well, then these measurements will not be accurate. You see two examples here. There is growing interest in looking at this RV free wall strain in patients with arrhythmogenic cardiomyopathy, and there is the recognition that some carriers, gene carriers, may have abnormal RV function detected by RV strain. The caveat is a higher value of 20%, and by higher I mean ignoring the negative sign. So for example, 23 or 24 may already signify pathology in specific settings. Clearly more data is needed here, but is an interesting concept to looking at RV function. RV strain has been looked at in many disease states, including cardiac amyloidosis, HFrEF, HFpEF, coronary artery disease, pulmonary hypertension, as well as cardiac transplant recipients, and patients with a left ventricular assist device or planning for left ventricular assist device to predict whether the RV will sustain the circulation once the implant is placed. Moving away from 2D to 3D measurements, it makes good sense. Here you want a decent frame rate, and we're looking at 20 to 25 volumes or so per second. To acquire, you will get a good look at all segments of the RV. As you can see in this illustration, it gets you the inflow, the outflow, the RV apex. And quickly speaking, there is a growing number of publications showing that the upper limits of normal for these values. The upper limits of normal for the RV and diastolic volume index for men is 87 milliliter per meter squared. For women, it is 74 milliliter per meter squared. For end systolic volumes, for men is 44 milliliter per meter squared, and for women it is 36. So you can see there is a sex difference. Also, it is recognized that as individuals get older, these volumes decrease and ejection fraction increases. On average, end diastolic volume increases by 5 milliliters per decade, whereas end systolic volume decreases by 3 milliliters per decade, with an ejection fraction increasing above 1% per decade. The lower limits of normal is at 45%. As you expect, given the lower ejection fraction of the right ventricle compared to the left ventricle, to maintain the same stroke volume, the upper limits of a normal end diastolic volume is higher for the right ventricle than for the left ventricle. And again, there are growing data showing the association of RV volumes by 3D by echo with cardiac outcomes. Talking about the right atrium, it is possible to do right atrial dimensions medial to lateral, superior to inferior, and they have been indexed to size. For example, the medial to lateral dimension in apical four-chamber view, the upper limits of normal is 2.5 centimeter per meter squared for both men and women. For the long axis superior to inferior, it's 3 to 3.1 centimeter per meter squared for men. But if we look at volumes, you can see that the maximum volume and systole before the tricuspid valve opens is 39 milliliter per meter squared for men and 33 milliliter per meter squared for women. In general, RA volumes tend to be less than the LA volumes, and there have been different approaches to measure them, either with the summation of discs method or with the area length method. Unlike the left atrium, we have only one view to rely on. There are now growing data for RA volumes by 3D. And there are data showing the association also of RA volumes with right atrial pressure in patients with cardiac disease. The higher the pressure, the larger the RA. I'll stop here in talking about the RV structure and RA volumes, and let's talk about pulmonary hypertension. The definition of pulmonary hypertension is based on the mean PA pressure, not the PA systolic pressure. First, it was 25, and that has been lowered to 20 millimeters mercury. The definition of non-cardiac pulmonary hypertension is a situation where the mean PA pressure is elevated, but the wedge or the left ventricular end diastolic pressure preferably is at most 15 millimeters mercury with increase in the pulmonary vascular resistance. These are cardiac cath criteria. I'm bringing them up as we go through our discussion of how we will evaluate pulmonary artery pressures. So what is an ideal situation? The ideal situation is if I can give you all that info that you get by right heart cath. Realistically, we can do good with some measurements, but not really the same as a right heart cath. We can do PA systolic, diastolic, mean pressures. We can provide insight when we look at the whole study about the etiology of the pulmonary hypertension, be it cardiac or non-cardiac, for example, valvular issues, HFrEF, HFpEF, congenital heart disease. And clearly, it's an integral part of the evaluation of patients of pulmonary hypertension to look at their RV size and function, as well as RA volumes. These have been associated with outcome and are independent predictors of outcome beyond pulmonary artery pressures. So we rely on the TR jet, which we try to get from multiple windows by continuous wave Doppler with good alignment. You've already heard about the parasternal short axis view at the aortic valve level. You heard about the apical views. You heard about the subcostal views. We look at the subcostal views for IVC diameter, its collapse, and hepatic veins. We need this piece for RA pressure. I'll get into details with that shortly. If the case is referred to the lab with a concern of pulmonary hypertension, it's important for the lab to do its best to report the PA pressure. This includes injection of agitated saline through an IV line, or if the ultrasound enhancing agents will be needed for left ventricular endocardial border definition, then one has to go back and try to show the TR jet. In general, the feasibility of a TR jet is more than 90% when you look at patients who have pulmonary hypertension. And one has to reconcile the Doppler value with the 2D findings. For example, if we say there is a septum that is showing pressure overload, it does not make sense to report a PA systolic of 30 millimeters mercury. One or the other is incorrect in the example I just gave you. The jet has to be complete. So some people would look at this jet and try drawing conclusions. Does it end here? Does it end there? This is not a signal that you want to rely on. In comparison, this is a more complete signal. We use the modified Bernoulli equation, as we talked earlier in the year, and you add the right atrial pressure estimate. And so in this case, before adding the RAP, you have a PA systolic. The patient has a PA systolic of at least 52 millimeters mercury. Let's talk about PA diastolic. Here we rely on the pulmonary regurg jet by continuous wave Doppler. In the parasternal short axis views, we still need an estimate of right atrial pressure. Again, saline will enhance this jet as well as ultrasound enhancing agents. Feasibility is lower than the TR jet in patients in general, including those with pulmonary hypertension, but in that group it is more than 70%. And the velocity we care for to estimate PA diastolic is the end diastolic velocity. Let's look at that example. This is an end diastolic velocity of 2 meters per second. If you do the modified Bernoulli equation, then the PA diastolic pressure is at least 16 millimeters mercury before adding RAP. PA diastolic pressure is also of interest in assessing left atrial pressure in the absence of pulmonary vascular disease. How about mean PA pressure? This is the expression that you can use to estimate mean PA pressure. It's the diastolic plus 1/3 pulse pressure. So if you have a complete TR jet, a complete PR jet, you can get it this way. Another approach is looking at the peak pulmonary regurg velocity as for that velocity squared, with or without adding a right atrial pressure. In many patients with significant degree of pulmonary hypertension, right ventricular diastolic pressures are elevated, and it is more accurate when they are taken into account. The advantage of option 2 as opposed to option 1, this is a single measurement, whereas here you're bringing several measurements, each with its own error. Another approach is looking at how fast flow accelerates in the RV outflow tract. If it takes a short time for it to accelerate, that's usually a patient with pulmonary hypertension, and that's an expression that was validated. In general, a short time is considered 100 milliseconds or less. Another approach is recognizing that the PA systolic pressure is related to the mean pressure. The higher the PA systolic, the higher the mean pressure. And so we can use the RV-RA mean systolic gradient from the TR jet plus a right atrial pressure to estimate mean PA pressure. This has been validated. It is also possible to use the regression expression you see below to obtain the mean pressure from the PA systolic pressure. So we have many tools at our disposal to look at, which is, as you can imagine, advantageous. That's the example showing you a markedly elevated mean PA pressure based on the peak pulmonary regurgitation velocity. If you do not have a TR jet, you have a PR jet, please look at it and try to estimate the mean and diastolic pressures. So we talked about pressures. How about resistance? The resistance ideally is measured most reliably by the right heart cath. A study was published a long time ago by Drs. Schiller, Lester, and Abbas that looked at estimation of pulmonary vascular resistance using the peak TR velocity as a surrogate of PA systolic pressure and the time velocity integral of flow through the RV outflow tract as a surrogate of flow. Quickly, I will tell you, this is at best PA systolic pressure, and we just said the pulmonary vascular resistance needs a measurement of mean PA pressure as well as wedge pressure or left atrial pressure ideally, and even the peak TR velocity is not the same as PA systolic. Likewise, the time velocity integral is not equal to flow. You need to account for the diameter of the RV outflow tract. So you can see that it's a gross approximation. A value more than 0.38 was 100% specific, but for a very large pulmonary vascular resistance, more than 8 Wood units. A value in 0.12, less than 0.12 to 0.15 is usually associated with a normal pulmonary vascular resistance. And for those interested in looking at values and how they relate to outcome, a cutoff of more than 0.15 predicted hospitalizations due to heart failure and all-cause mortality in 795 patients with CAD from the Heart and Soul study. So now we talked about PA pressures, and you saw that the RA pressure is an integral part of this. IVC size and how it behaves with inspiration is needed to assess RA pressure. Ideally, it's measured at 1 to 2 centimeters from its junction with the right atrium. And also you want to measure that change in diameter perpendicular to the lung axis of the IVC. An example is shown here where the IVC completely collapses. Sometimes this happens with spontaneous inspiration, but sometimes it takes a little sniffing to bring about this change. And there is a patient where the IVC is markedly dilated, doesn't change any, consistent with a very large or very elevated right atrial pressure. We and others have looked at the relation between mean right atrial pressure and the IVC collapse index, that percent change in its diameter. If it's at least 50% or exceeding 50%, then the right atrial pressure is usually less than 10 millimeters mercury. These are patients who were in the ICU, some were on mechanical ventilation, some were not. And you can see that in patients who are not on mechanical ventilation, these closed circles, significant association is present. But if you look at those with open circles, there was no relation between the IVC collapse index and mean right atrial pressure. So patients on mechanical ventilation pose a challenge to the use of the IVC collapse index. Based on the published studies, we can say that if you're looking at a patient who's on a mechanical ventilation, a diameter is the better metric of pressure as opposed to the collapse index. You just saw no relation in the previous graph. A diameter that is at most 12 millimeters was associated with a right atrial pressure less than 10. However, more than 12 millimeters had no predictive value, meaning you can see patients with, let's say, a diameter of 14 who still had a normal right atrial pressure, not an elevated pressure. The challenge of relying on the IVC, aside from looking at it in patients on mechanical ventilation, respiratory distress is frequent in the post-op setting where there are no subcostal windows. You can look at the mitral tricuspid inflow and the hepatic vein flow, similar to how we look at the mitral inflow and pulmonary vein flows. We can measure the acceleration time, onset to peak, deceleration time of the E velocity, E to A ratio, A wave duration, and you apply the same concepts, a high E to A ratio, short decel time, short acceleration time, all go with a high RA pressure in patients with cardiac disease in normal subjects. All of these time intervals will be short and the ratio will be high, and that's the challenge of relying on tricuspid inflow by itself. For hepatic veins, we look at flow in systole and diastole, the ratio between them, and we also look at what happens at end diastole with respect to duration and the amplitude of the velocity. The higher the late diastolic pressures in the right ventricle, the longer this duration and the higher that velocity, to the extent that the right atrium mechanical function is still preserved when it contracts. Example with different tricuspid inflow patterns, a normal pattern, low E, high A, if you would, in someone with a RV diastolic dysfunction but normal RAP. On the other hand, this is someone with a good degree of tricuspid regurg and a high E velocity, and that's another confounding variable that affects the peak E velocity that influences the reliability of the E to A ratio. This is a direct relation, but you can see wide scatter, and we do not necessarily recommend relying on E to A ratio only to draw conclusions about RAP. The hepatic vein flow is more useful in our experience. The systolic to diastolic velocity ratio in someone with a pressure less than 5, when it's 5 to 10, you tend to see similar velocities. Again, you can look at velocities as well as time velocity integrals. And the lower the proportion of the systolic flow, looked here as the time velocity integral of the systolic velocity, The higher the right atrial pressure, you can also use, instead of the time velocity integral, the systolic velocity by itself. Though if you want a better metric of flow, it's really the time velocity integral as opposed to the velocity. And you need to average cycles or acquire data at end expiration, but a single beat is not enough. Example from someone with a very large atrial reversal velocity and a high end diastolic pressure for the right ventricle. This is from a patient with pulmonary hypertension and severe RV diastolic dysfunction. Systolic reversals, similar to pulmonary vein systolic reversals, are seen with severe tricuspid regurgitation, but they are related to many aspects, not just the severity of the regurgitation, but also right atrial stiffness. The limitations for relying on hepatic veins are in pericardial compression syndromes, tricuspid valve disease, stenosis, and severe tricuspid regurg. Luckily, tricuspid stenosis is really rare, but nowadays we see more patients with clips, potentially prosthetic valves that is a challenge to relying on hepatic veins, the presence of arrhythmias, AV block, tachycardia, heart transplant recipients, and again, absence of subcostal windows. Similar to the left side, you can look at the E prime velocity and the tricuspid E to E prime ratio. And also you can look at that isovolumic relaxation time between the end of systolic ejection and the beginning of recoil of the annulus away from the apex, the E prime velocity. In patients with high right atrial pressure, this time interval tends to shorten. This is a study showing how the tricuspid E and annular velocity are acquired and showing a direct relation with right atrial pressure. There is the Bland-Altman plot. These were patients, some of which were on mechanical ventilation, included some normal, but really several patients with cardiac pathology involving the RV. An interesting study from Japan was published several years ago, here specifically looking at patients with pulmonary hypertension. And again, you see a very tight and nice relation and a cutoff value of 6.8 predicted patients with worse outcomes, albeit a smaller number of cardiac events. Limitations are in patients with pericardial compression syndromes that can affect the free motion of the RV free wall. These velocities can decrease, not because of function problem of the right ventricle diastolic function, but because of the adhesions, tricuspid valve disease, stenosis, and significant regurgitation, arrhythmias, and in the absence of apical views. It's a quick summary. If you have an IVC collapse that is 50% or above and a systolic more than diastolic, pressure is 0 to 5. On the other hand, if the IVC is less than 50% collapse and flow happening only in diastole, that is 20 millimeters mercury or above. One approach could be you can start with the IVC collapse and its dimension, and then when you are in that middle range, you can look at the hepatic venous flow and try to tease patients into more refined categories. Show you quick examples. There is a normal RARV and there is a very large RARV. As you can see here, that can pose challenges in getting good alignments with tissue Doppler signals on the lateral side. Very large TR and PR and diastolic velocities, small systolic velocity relative to the diastolic velocity in the hepatic veins, signifying that RA pressures are as well elevated. A 4-chamber view, as you can see here, this is, I would say, really an attempt at a 4-chamber view, and it is not a proper view for the left ventricle. Important to remember when you try to get good Doppler alignments for the left ventricle. A septum that is flat in end systole and end diastole, consistent with pulmonary hypertension and an elevated mean PA pressure. The question frequently comes, is this cardiac, is this non-cardiac pulmonary hypertension? So if we go to sort of the purest forms and look at somebody with non-cardiac pulmonary hypertension, you typically see an E to A ratio less than 1 with low mitral E velocity. Septal velocities can be reduced for the E prime because this is contributed for by the RV. In comparison, the lateral velocities are normal. That tells you that the diastolic function of the left ventricle is normal, as is the LA pressure. In comparison, in someone with cardiac components of pulmonary hypertension, like group 2 pulmonary hypertension, you see a predominant E, and both septal and lateral velocities are reduced here with increased E to E prime ratio. This is the performance of E to E prime ratio, showing high value in patients with group 2 pulmonary hypertension as opposed to non-cardiac pulmonary hypertension. You can see all patients had a lateral E to E prime ratio less than 8 here. So remember, it's the lateral ratio that matters if you want to tease things out. This is a beginning. We certainly need more data, and these are cases that should go for right heart catheterization. Let me give you a quick summary on this slide for some numbers that one should try and memorize. A basal diameter in the focused view more than 4.1 centimeters is abnormal, with thickness 0.5 centimeters. The distal RV outflow tract diameter 2.7, the proximal more than 3.5 centimeters, the RA major dimension 5.3, but if you want to index it, it's really 3 to 3.1 centimeter per meter squared. For the minor dimension 4.4 indexed, it's 2.5. In maximum end systolic area for the right atrium is 18 centimeters squared, a TAPSE 1.7, the tricuspid S prime velocity less than 9.5 is abnormal. The myocardial performance index using conventional Doppler, the TR-jet and RVOT flow more than 0.43 is abnormal, by tissue Doppler more than 0.45. Fractional area less than 35, tricuspid E to A ratio less than 0.8, more than 2. These cutoffs are in patients with RV disease. In normal subjects, loading conditions will influence them a lot and they are not really of value. Tricuspid E to E prime ratio more than 6, and you can also look at the decel time. I want to spend the remaining time to talk about tricuspid regurgitation. Similar to the mitral size, when you think of the impact of the lesion, think of what does it do for the RV size and function. And if we are not using 3D, think of end diastolic areas and end systolic areas and fractional area change here. RA volumes, tricuspid valve apparatus, how much pathology there is. Look at the consequences of the tricuspid regurg with the IVC diameter and its collapse. Look at the tricuspid inflow and what happens to the peak E velocity, hepatic venous flow for systolic reversal. And then look at PA pressures. If these can be estimated, they can help you identify whether this is primary or secondary tricuspid regurg. But certainly many other findings should be brought in, including clinical data and 2D to assess that. Nowadays, we can image the tricuspid valve with 3D, not just transesophageal, but also transthoracic, and showing you the atrial and ventricular perspective, showing you examples of a pathology that can be readily identified here. I'm using TEE examples, a big RA, a big RV, and you can see here leaflets that are not coapting. This is not somebody who will end up with an inconsequential TR. Going in here, I am expecting severe TR. You can also look at 3D nicely of the tricuspid leaflets, and in systole, there is really a hole where the 3 leaflets are not meeting one another. Now that we've looked at the 2D, taken into account RV and RA size, and ideally, if you can measure, you want to measure, we apply color Doppler. Of all the measurements, in my experience, color Doppler tends to be the least reproducible, more variation between different observers. And so I'll show you an approach that we looked at and when to use it and how to use it. First, because the aliasing radius, if we want to use the proximal flow convergence method, depends on the aliasing velocity. The ASE guidelines, native valve regurg guidelines, recommended the most recent ones looking at that radius with a Nyquist limit of 30 to 40 centimeters per second. And so if you are able to measure the PISA radius on a view like this one, it is less than 0.5, it's mild, more than 0.9, it's severe, and in between, we're looking at moderate tricuspid regurgitation. How about Vena Contracta, which you want to measure from several views? These include the apical short axis as well as the RV inflow view. Some views are clearer and more reproducible than others. At the end, you want to use data that you like and you trust. A radius less than, a vena contracta less than 0.3 goes with mild TR, 0.7 or above severe, and in between moderate. You can also look at the jet area. A small jet area in a central jet, not an eccentric jet, goes with mild TR less than 5, more than 10 severe TR, in between moderate TR. All of these color Doppler measurements are heavily dependent on the aliasing velocity and the color gains, so one has to look at these carefully. You can also work with 3D vena contracta with an area more than 0.4 centimeter cubed, signifying severe TR. This is the principle behind the flow convergence. I believe all of you are familiar with that. And so if you end up with a regurgitant orifice area less than 0.2 with a regurgitant volume less than 30, ASE guidelines say this is mild, 0.4 or above, and a regurgitant volume 45 milliliters or above, that's severe. And in between, you are looking at moderate. The problem with trying to be very strict here is you can see 15 milliliters can easily throw you or result in a very different conclusion from mild all the way to severe. Again, these are data obtained by color Doppler. This is an example of applying the PISA method. And so we have the radius, we have the aliasing velocity, remember, between 30 and 40 centimeters per second, and we have the peak TR velocity. We ended up with the effective regurgitant orifice area in the severe range. You multiply that by the time velocity integral of the jet, and you are converting the area to regurgitant volume. Because the approach with the PISA results frequently in underestimation, and that underestimation is related to the ratio of the aliasing velocity to the peak velocity by continuous wave Doppler. Investigators have looked at trying to correct for this underestimation using a correction factor that you see here. The numerator is the peak velocity, the denominator is the difference between that peak velocity and the aliasing velocity. It was validated against Doppler by itself. Basically, the tricuspid regurgitant volume was quantified as the difference between the tricuspid inflow, so area of the tricuspid valve multiplied by the time velocity integral, and the RV outflow tract is the net output of the right ventricle. And it was adopted in several investigators. However, I would say the guidelines do not specifically bring that issue up. How about continuous wave Doppler? Many people think that a high velocity is associated with a severe TR. There is no direct relation between peak TR velocity and TR severity. Severe TR can be associated with a very small velocity. That's an example. Look at mild TR, look at severe TR. Here, what gives away the severity is the brightness of the signal, very similar to that of the tricuspid inflow, telling us that the number of red blood cells reflecting the tricuspid regurg signal are very similar to those crossing the valve in diastolic. And notice the early peaking because of the rapid equalization of the right atrial and right ventricular systolic pressures. Hepatic venous flow showing systolic reversal. This is a very useful finding, and that's a summary of the ASE approach. And again, the approach relied on looking for specific criteria of severe TR, which if met, you assign the severity of TR. If were mild, if met, mild TR, although they do not give it a hierarchical approach and they do not tell you which is sort of more reliable than another. But in between, they recommend the use of the vena contracta and the PISA and the color Doppler measurements. We did a study with Dr. Yang Zhan and Dr. Deepan Shah a few years ago, looking at how echo and CMR compare with TR severity in 337 patients. You see an example here in someone with severe TR by color Doppler with large RA and RV. And we looked at several criteria to diagnose severity using CMR volumes defined by 45 mLs to say severe TR. I will quickly take you to some important messages. If you look at the systolic reversal in the hepatic veins, if you look at the IVC maximum diameter of at least 2.5 centimeters, the cutoff of 7 millimeters for the vena contracta and ERO of 0.4, you're looking at pretty specific signals. But many of the color Doppler signals tend to have lower accuracy. This was a TR ERO that was with the correction factor that we talked about. A normal RV function with a large RV should trigger the concern that there may be a significant degree of TR that has not been covered. Upper normal for RV and diastolic area is 12.7 centimeters squared per meter squared for men. So we looked at a hierarchical approach to assess TR severity, and basically we looked for the more solid, so to speak, findings. For example, a dense triangular CW jet like the one I just showed you, or a sine wave appearance for that tricuspid inflow TR jet. If you see this and then you see systolic reversal of hepatic vein flow, that's the end. This is severe TR. If you do not have these two signals, then you look at the RV function. If the RV is enlarged with preserved function, then again, you're looking more likely at severe TR. As these signals become less available or give you conflicting information, that's when you bring in the color Doppler and you use three criteria so that you can break the tie between the three. I'll show you a quick example from a heart transplant patient who presented with fatigue, and you can see here tricuspid leaflets in the RV inflow not coapting with a good degree of color Doppler. Look at the flatter septum during diastole as opposed to systole. The LV function you would notice is also depressed here. And then the apical view showing us the very large chambers in the leaflets that are non-coapting. Notice that the color jet is not very helpful or very complete here, but all the 2D parameters were heading in a direction of a significant TR. Notice the markedly dilated IVC and hepatic veins here, and the TR jet by continuous wave Doppler consistent with severe TR as the large systolic reversal signals. With that, I will stop and thank you for joining me today. If you have any questions, I'm happy to answer if there is maybe time for a couple of questions. Okay, I do not see any. And with that, thank you for joining us today. And we look forward to you joining us in other presentations for this multimodality imaging sessions.